doctors that have really supported us. I want to also say that the doctors from Cork and Galway, Derek and Christor from Cork, and Greg and Marcia from Galway apologise that they couldn't be here, but they wished us all the best. But we did want to, we haven't done this before, but we want to acknowledge the support that the doctors have given to us and the support staff. So with that, we want to actually make a small presentation. Maybe Tommy could show us what it is. We've got a glass bowl commissioned with our new logo. So if you don't mind accepting it. So Tommy, could you present one to Hussein? Adrian? So So Adrian is on our newest member of our committee and make a presentation to Justin Gagan. Tom? So Tom O'Donoghue, who has been on our committee from day one, from Tipperary. So Tom is going to present to Catherine Donoghue from the HSE. You haven't heard from Catherine today, but Catherine is the manager of the Treatment Abroad scheme and a great supporter to us. Helen. So Helen is not in the last few years joined our committee. So Helen is going to present to Donal O'Shea. And as we said, Donal is one of the people why we have our group and why we have a net service in Ireland. Mary? Mary? So Mary from our Cork office is going to present to Lisa Cullen, the nurse specialist in St. Vincent's, and Lisa does a fantastic job on all our behalfs. So we just wanted to recognise that the clinicians here, I'm including you, Catherine, do a fantastic job supporting us, making things happen in the world of NETs for us all, and we want to recognise that. And we have the same for the doctors in Cork and Galway, and a few others from the background, like the Stephen Skeen, who does radiology. And Jerry Daly, who makes a lot happen in St. Vincent. So we'll present them to them separately. So with that, I'd like to start the Q&A. I suppose I'll ask, does anybody have a question that they'd like to ask straight away? So, go ahead.
The other question I wanted to ask is, how many people in this room, if they were told just scan the QR code, would be very comfortable doing that? Very comfortable scanning a QR code. And how many would not be comfortable scanning a QR code? Okay. So that's interesting for us because the questionnaire that Dermot alluded to is scan the QR code. and go online and do the questionnaire. So, you know, listen 50%. I'll hold on to it, yeah.
Oh yeah. Take the microphone, please.
Yeah. Good afternoon. I'm Kieran. I'm a rebel. I'm from Cork, and this question I think would be for Mr. Gagan. It would be, could you please explain to me the exact function of the Creon tablet? And I would take my Creon tablet with my Smatuline gel, maybe 6 tablets a day over a course of 3 to 4 days. But should I continue to take a Creon tablet daily after that?
So the Creon, just as regards Cork, I married someone from Cork, so I understand what you say when you're saying you're a rebel. Closer. So the Creon replaces the juices that the pancreas makes. So the enzymes that digest your food are you know, you may not produce enough if you've had a pancreatic resection, or if you're on a somatostatin analog, it may reduce the amount of juice that your pancreas is making. So you may be a little bit short on enzymes because of that. So you should continue to take the Creon if you're still taking the somatostatin analog. The amount you need to take is probably something you arrive at by trial and error, really. You know, in the old days, the advice was you just take 1 tablet at meal times and that's it. But we're finding now there are many patients who've had pancreatic resections who need to take 2 or 3 or even more Creon tablets. So short answer is yes, keep taking it.
And if I can just come in, we've learnt a lot about the Creon over the years. So it is you cannot take too much. People wonder, oh God, is 8 tablets too much? Not necessarily. It is best to take it throughout the meal. So you take 1 at the beginning, and then after a few mouthfuls you take another 1, because that's the way the juices would arrive, meet the meal as you're having it. And some people find that they need it for the first week after the somatostatin injection, but not for the next 3 weeks. Some people find they need it all the time. And the way you know is if you stop taking it and your bowel motions become yellowy and float and don't flush away, then you need to go, or you have wind or whatever, then you need to go back on it. But there's very few tablets we say you cannot take too much of. And that trial and error thing to get to the right number for you then should stay pretty steady for you for good. I don't know, Lisa, do you have anything to add to?
I don't think so, not to that. I think that's, yeah.
Another question, John? Do you want to just, we'll do this one first and then do yourself, yeah?
Yeah, this lady here suggests that the answering of the question, can the person stand up, because the people down here cannot see. Okay?
Hi, I'm Fiona, and actually it's to the audience here more than the panel. I take Affinitor, and I'd love to know if there's anybody else taking Affinitor, or how many people take Affinitor here. Is anybody else on Affinitor?
Anybody else taking Affinitor in the room?
One other person. It's just that I've never met anybody on it, and I'm on it, and I take 6 tablets a day. The Affinitor is 7.5, so I take 2 of them a day. And I'd like to know, maybe somebody might have some information about Affinitor for me. So there's only one other person here on Affinitor? Yeah.
Do you want to make a comment?
Yeah.
The other name for it is, oh yeah, the other name for it I've just found out is Everolimus. So anybody on Everolimus? No, so Affinitor. So we don't have oncology on the panel, so we're not specialist in that. So one thing we don't do in our team is kind of bluff. I don't have much to say about it, and I do know at the MDT when we're making decisions about the right treatment at the right time, which Justin covered in his talk, Everolimus is one of those things that we say now is the right time for it, and then it's off to meet with the oncologist. Justin, do you want to?
Yeah, I mean, I think that there's a very good evidence base to support the use of Everolimus. It's been really well studied in randomized trials. And it seems to be most suitable for people with those sort of medium grade neuroendocrine tumors. It's a particular class of tumor or particular class of drug that targets a particular pathway that's been really picked apart very carefully in biochemical studies. I mean, because I'm not prescribing it, I would not consider myself to be an expert in its side effects and all that sort of information. So it's really a question for an oncologist. We don't have an oncologist today, but maybe next time round.
Obviously, I'm not a doctor, but just my engagement in the international scale. I mean, Everolimus is a very common drug used by so many patients around the world. So it is a standard drug treatment and standard pathway for a NET patient.
I just wanted to ask a question. Is there any particular food or fruit that should be avoided if somebody is suffering from the effects of diarrhea from the cancer? Is like tomatoes or something? Is there a particular food that should be avoided, completely avoided?
I know we don't have a dietitian here with us, but I'd have to say that it's a real trial and error. It's very individualized, and I think that's, people say avoid these vegetables and, certain fruits, citrus fruits and stuff, but I really think it's a more individualized sort of plan, and it's always a great idea. We had a great dietitian with us before, Deirdre Burke, and she's moved on, and we're just waiting for a new appointment, but I think it's really, really important that every NET patient get to see a dietitian, for their symptoms of the disease and the symptoms of their treatment too.
And Deirdre, who left us, I learnt a lot about the Creon and the timing of it within the meal, and I was just reminded there that the Creon can be denatured by heat, so it needs not to. Do you keep it in the fridge? Is that what you're told to do? No. Oh, don't carry it around in your top pocket, so don't carry it at body temperature. Keep it in your... And take it with cold water. Okay. Okay. Are there any other Creon tips from... Don't store it in the sunshine?
Can I add that there's Deirdre presented at one of our previous talks, maybe 2016 or 2017, and we recorded that, and it's on our YouTube channel, so you'll get it on our website, and you can jump to the YouTube channel and see all the other videos, but one of those is the talk that Deirdre gave, and she went into a lot of detail about Creon and how you take it, and I think that was one of the biggest tips, was to take it with water and not with your tea. As you said, it's denatured by the hot substance.
It's probably fair to say there's lots of reasons why you can have diarrhea. So the answer is going to be individualized to your situation. So if you've had a small bowel net and you've had a big small bowel resection, then that might be the cause of it. And you can take as much Creon as you want and it won't make any difference. If you've had the lowest part of the small bowel excised, and that's a very common site for a primary, I don't have my mic technique, that can affect the absorption of bile salts. And if bile salts get into your colon, that can cause terrible diarrhea. And that's usually very well managed with a different medication that mops up bile salts. So there are a lot of different scenarios which can provide an explanation for diarrhea. And it's going to be very specific to each person, I think.
But a visit with a dietitian can help to maybe identify things?
I think that the question was about diet, Margaret, wasn't it? You asked, yeah.
I suppose if you're on chemotherapy, it can have the effect of causing diarrhea as well, which might not be related to diet per se, so I suppose there's other
Yeah, treatment.
And I'm just going to step out. I'm on call, so I need to take a call that's just come through from the hospital, and I'll be back.
Can I add another side question to that? The 5-HIAA test and the list of food you're supposed to avoid. From the St. Vincent's group, the form says to avoid vegetables, which seems at odds with the general thinking of that. So can you comment on that to the patients?
I'm not sure that I knew. I only know that, the list we have is, I mean, it's a long list, and I hate giving anyone the 24-hour urine collection because it's like avoid, every vegetable, fruit, wine, etc. But that's the up-to-date information we have, Mark. But you're saying that it's different in other countries. Is
I think it's more the vegetables that are not included normally,
Yeah.
and yet Vincent's just says vegetables avoid.
I'm sure we could probably
Maybe Hussein could look at that and
yeah,
go
exactly.
forward.
Yeah.
Yeah, so these things might have. Try again. I'm just talking. All these
Maybe you
things
can
in
hear
the list might have some effects on the results. Although, as you know, when we look at the results, we just don't look at just a little bit of an increase in the results, in the final results. So we look at doubling or tripling of the normal value. So although these vegetables or whatever might have a little bit of an effect, but to us, when we look at the results, we look at massive increase in the number. So even if you do, some of you find it very difficult, you have to take the vegetables, you can't change your diet. You try your best perhaps, but it's not the end of the world if you couldn't. This is the message. But we'll look into that and look at other center recommendation.
Thank you. I'm going to ask a question. Some questions have been given that people prefer not to stand up and say. So there's a patient here who has high calcium in the blood, and they are on Zomita, and they want to know how long they can stay on it, and are there any major side effects?
The Zomita is a very good treatment for high calcium. You can be on it indefinitely, basically. There isn't an end time for it, but we will often be able to control the calcium with Zomita for a number of years, and then if it were to climb again, then there are other treatments that can be added into the Zomita, and Zomita is very, very good. So it's a treatment for osteoporosis at doses. At high doses, it's a treatment for high calcium in the setting of a net. Sometimes actually the somatostatin or sandostatin injections will control the calcium, and the Zomita won't need to be added in at the start, and high calcium doesn't become a problem it's only becomes an issue, I would say, for maybe 10% of net people.
So they can continue to take it.
Yeah.
Any more questions? Okay.
I'd like to ask you a question about Creon. On my last visit,
Closer.
Can you hear? Oh, sorry. My last visit, I was prescribed Creon, and when I picked it up from the chemist, he had a negative reaction. He said, "I don't know why you've been prescribed this. It is not for your condition." I didn't take it.
So, well, if it was prescribed, then I'm assuming it's an appropriate indication. The one thing Creon will never do is cause harm. And as I said, there's very few things you can say that about. in medicines. So I would think it was prescribed for you at a net clinic. Okay. Then I'm surprised because our links with our pharmacy colleagues are incredibly positive. So I can't explain how that happened, but I would suggest that you would maybe, that I'll have a little chat with you at the end, just on the individual condition, and then talk to you about what to say to the pharmacist. And if we need to phone the pharmacist to explain why we've started it, but she was told it's not for her condition. So that if it was a supply issue, that'd be one thing. Yeah. And some people do, so one of the things that Dermot O'Toole, when he kind of came to us, we were using a lot of Creon, and he wasn't using much Creon at all when he came back from France. And he didn't really believe in it. And then he saw the difference it made, not to everybody, but to a certain number of patients, the Creon just makes a big difference. In other patients, when you get to the bottom of the bile salt problem, the question treatment is brilliant. And then for others, Lisa mentioned it, and I was out of the room, but the FODMAP approach for just, we call it plain irritable bowel syndrome, where you get advice from a dietitian about leaving foods out of your diet and then reintroducing them one by one to see what triggers diarrhea for you, and then you avoid that, is a good approach. So we'll have a very brief chat at the end.
I think we can also, on the Creon and diarrhea, we can maybe ask Owen and Mary to start up a discussion. People can give their opinions about, what their impact has been, their experiences, and maybe that might help you a little bit as well.
Sorry, I was just going to contribute as a pharmacist to say that in pharmacy, mostly we would see Creon given for cystic fibrosis patients.
Up to your mouth here.
And I think it points to the fact that maybe we pharmacists are not as well versed in NET as we might be, and that when you're communicating to your GPs, it might be a good idea to communicate to the pharmacists as well. All right, sorry, thank you.
Nice one.
I'm going to ask another question that was given to me. So a person with secondary liver metastases but unknown primary, they're on monthly somatostatin analogues, taking sandostatin octreotide, short-acting, once a day to control the symptoms. That they have flushing and palpitations. They're over a year on this. Is it normal for somatostatin injection to take a while to work or settle in? Are there other options available to avoid daily injection?
So are they're not on the monthly injection?
No, they're taking daily, they said, short-acting octreotide.
Okay.
And they want to know, is there alternatives to
that? So my journey with somatostatin has been almost 30 years, and it started out life as a 3 times a day injection, and it's still available as a 3 times a day injection, which we would occasionally use just to see if someone would respond. The first person I gave it to in London came back with a big sign for me, because he'd had diarrhea for ages, and he started on this injection that he thought I had made because I drew it up and gave it. And he came back with a big sign, Dr. O'Shea's magic cure for just tummy ailments, and a pint of Guinness on the front of the sign. But very quickly it became a once-a-month injection. So if the once daily injection is working for what the symptoms are, then I would be going back to look to transfer to a monthly injection, and that would be the thing to do for sure. And I think actually, I'm just trying to get up. Was it Alan's final slide? Was when you have rare. I got to read it because it's brilliant. Yeah, for rare disease, go where rare is not rare but is common. So I now fully understand why you were told it's not for your condition, because it's a rare condition, and CF is what we use Creon for. or so I think it was the pharmacist just was saying, no, not your condition. And but we'll sort that out. And communicating with the pharmacist, why don't we copy? I'm not saying you'd want to be receiving all the letters, but we should be communicating more. Yeah.
I think your answer then to that person about the short-acting somatostatin analog is to go back to their physician and talk about it's working.
Yeah.
Can I go on to a longer-acting one?
Yep.
Yeah. And I think, if you don't mind me saying that, some of the things, there's a lot happening in that field of somatostatin analogs, and they're talking about an oral tablet as a possibility in the future, and they're talking about a subdermal one that we can all just easily give to ourselves. So to avoid this, big needle bottoms every. So there's a lot happening there. Any more questions? Oh, one at the back and then yourself.
Yeah. My question is for Donal. With lung nets, I'm one of the patients, the rare ones, that have unexplained weight gain. And I heard Donal talking about this new weight loss injection. So I want to ask, when I asked Eric Power, he said he'd have to get on to Donal to see is it suitable for patients who have neuroendocrine cancer. So my question is, would it be suitable for me to help get down some of the weight? Thank you.
What time does this session finish at? Yeah, sit back, relax, yeah. So, yes. And I can sit down at that. It is absolutely suitable. There's very good evidence around. So there's developments around the somatostatin injections and moving on to, tablet and easily administered subcutaneous. In the field of obesity, our understanding is much improved. The treatments we get are improving. And I mentioned earlier, myself and Justin have worked in the obesity space over the last kind of 20 odd years as well. We have had no treatments for obesity that were tablet form or injection form up until the last really couple of years. And now we have, in the one you're talking about, which is Ozempic at the moment, we have a treatment that is effective and delivers about 15% weight loss. We have treatments coming over the next couple of years that will give 25% weight loss. Those treatments, everything in the body functions better. With even 10% weight reduction. All your immune cells, your heart, everything works that bit better. And the other thing we know is that hormones cause weight gain. So hormones can cause weight loss. So if you have too much thyroid hormone, you lose weight. But that whole field is expanding. We heard again when Alan's presentation around that impending doom, that sensation. Hormones deliver hormones make you feel how you feel. Hormones regulate mood. Women know this within their monthly cycle, how the mood changes. Men are steady state on the hormonal front, but people go for a run to get a hormonal benefit in their brains. But hormones affect weight. The treatments we have are hormone based, and people with nets should be getting them the same way as people without nets.
Thank you, panel. I'd like to ask the panel for some clarification on the requirements for a chromogranin A blood test. My concern here is whether or not one should fast beforehand or not, and secondly, whether or not you should refrain from taking antacid supplements for some time before you have had it. In my case, I'm on antacid supplements for reflux for the last 30 years. It's not possible for me to avoid taking them for 3 or 4 days or a week before a chromogranin A blood test. The result being a false positive, I'm told. Thank you.
So chromogranin is one of the markers in the blood, as most of you know, that we check together with your scans to see the treatment response, to see how your tumor is steady or not over time. And with the chromogranin, we measure it in the blood. It's inside the cells of the tumor, so it tell us about the tumor. You don't have to be fasting for a chromogranin A test, but as you said, the tablet for the stomach, which is like Nexium, the pantoprazole, all these proton pump inhibitors, as we call it, they could affect the results, and you might need to come out of them for 3 days before the test to have a more clean results. But again, in your situation, if you can't avoid taking this medication, as long as you tell your physician, your net physician, that you are on them while having the test. So when you come in 6 months' time for your next assessment, for example, or this could be a year, and again, you repeat the test while on the tablet, so we know that, and so it's mainly to compare the two results to see your tumor response. And again, we are not looking into a little bit of an increase or a little bit of a decrease in the value. We are looking for a doubling of the value, etc. So this should be okay as long as you let us know.
And I think it's really that point's really important. If some people get very wedded to a very precise number, you know, and the chromogranin is 87. And the next time it's 92. And for us, that's the same. If we measured it across the day, it would be vary within the day. So it is a fold shift you're looking for. And once the situation is the same, once 1 year to the next for the individual, then that's the important thing.
One little thing to it. Also, just to say that the chromogranin A is just one part of a lot of different tests. So you do the 24-hour urine collection, your scan. So we don't just take it on its own and look at that. So it's part of a series of tests.
To add to that, you know, as a patient, I go in, I take my bloods and for testing. Like in the early years, quite often I go and the sample for the chromogranin A was not put on ice, so it basically invalid the test. So I recommend as a patient, when you're getting chromogranin A, remind that the sample has to go on ice. So I just want to ask Catherine, if you don't mind, what's happening on the treatment abroad scheme, and what's your day-to-day experience of how it's all working and what's going on? Not working?
In relation to NETS patients. Yeah, okay, so the night before last I had a phone call with Dermot O'Toole. He was concerned with PRRT becoming available in Vincent's, that there might be some difficulty with patients who are already in treatment in other countries continuing to access that care. That sorted within a few minutes. I had emailed the office, so anyone who's already receiving the treatment abroad will continue. We will also keep the ability to go abroad in place until it naturally falls away. The requirement to travel abroad falls away. So there will be no impact on the ability of patients to access healthcare abroad under the treatment abroad scheme. And that's one of the main contributing factors to that, is that your consultants have been engaging with us the whole way along. Dermot will always pick up the phone, Donald, Restart, all of the consultants pick up the phone if there's a problem, and that's a huge benefit for your care, that they have taken those steps to mind you. Thank you.
If I can just say one additional thing, Dermot mentioned earlier in the morning that we had our centre of mediocrity, our centre of excellence, you know, we're a centre accreditation a couple of weeks back, and Shell Oberg from Uppsala was one of the two and the feedback has been very positive. And it was really incredible to have someone of his stature visit, review how we do it. But when we told him that PRRT was starting up here in the next number of months, he visibly slumped a little bit, and he said, "But does that mean it's over?" So we have had a special relationship with Uppsala, but the patients who have travelled from Ireland to Uppsala have made an incredibly positive impression in Uppsala. I mean, have been ambassadors for our country in Uppsala. So it has been a really special relationship, and we don't want it to finish. So he was very reassured that Irish people will continue to travel to Uppsala in that bridging period before we're fully up to speed. I just thought that was a very positive vibe from him, you know, and it was very affirming for the service.
I think Irish patients are also going to Rotterdam as well, of course, and to London. And Catherine, if you want to comment the different places they go.
Well, Uppsala have been very good in relation to accommodation, and that has been in no small part due to Tommy and Mark organising that the cost of accommodation is included under the treatment costs that come to us, because the HSE cannot pay for your accommodation if it's not in a hospital. So I know Tommy's still working on Rotterdam, but we'll get there, and hopefully before the requirement to access those services finishes. But the other public health care services throughout Europe, whether it's for NETS patients, whether it's for paediatric transplant patients, regardless of who it's for, our relationships with the public health services throughout Europe has been fantastic, and they've been very good in accommodating Irish patients, because we don't have the population to support a lot of the requirement for these services in the country.
Question from here. Okay.
Okay, so we've had situations where patients with carcinoid syndrome have had to have emergency surgeries while not in a centre, so they're not in Galway, Cork or Dublin. And the consultants there basically ignored everything they were told about the syndrome and just carried on and started the operation, and they've ended up in very, very bad straits. One of them went into carcinoid crisis, and basically they were left go through it until the end, and that was it. We have another patient that went abroad, and they had to ring back to St. Vincent's to get some feedback on what was going on, because the consultants there again ignored the patient. So what the question is here is, could the centre draft a letter explaining basically that the patient has carcinoid syndrome and what is needed, because a card with the information on the back of it is not actually cutting it when you're kind of outside the country and that. So if say a patient has been confirmed with carcinoid syndrome, that automatically a letter that's already been set out for yourself, a template letter, just gets sent out and said, look, if you get stuck somewhere, this letter can be put forward. And second on that is we have no procedure or protocol, whatever, for how to actually deal with carcinoid crisis when it occurs. We have our protocols, pre-op protocols, etc., for the infusions, but if someone actually goes into it, there is nothing definite out there yet actually what you're supposed to do. Now, luckily myself and Mary, because we're in the thick of it, we have one that we use ourselves because we learned it from a patient elsewhere, but we're not medical people, so we can't tell people this is what you do. So that would be another good idea as well. On top of that, that's looked into as well, whether it's through ENETs, to come back with, right, this is what you do, for carcinoid crisis if it actually occurs. Okay, thank you.
There's a bit of like, okay, thanks for the question. So at the moment we just do this through individual letters if we know someone is going for a surgery. So we do mention that these patients need at risk of carcinoid crisis, and we have a protocol to be attached with the letter. But I got your point there in case this just happened. Usually our experience, the patient would have told us they are going for a procedure. We'll go back to us, then we'll do another letter. And maybe through the new website, we need to have some more information about carcinoid crisis through the new website. With regard to the protocols, they are mainly about prevention, as you mentioned. With regard to the management, I think it depends on case by case basis, and it's like of management of any crisis. So it depends on how severe the situation is. Carrying a card is important. Information through website and individual letters, I suppose.
Can I say though, Hussein, that maybe what Owen is saying there, that when you're giving out the card, that you could also give a letter, so without the patient having to say, I'm going to go for a procedure, so that they get the letter, which is sort of a official authority that when they're going for a procedure, they can show that, not just the card, but show a formal letter from their clinician in St. Vincent's or wherever.
Yeah, this is something we should start to maybe work on.
I think the reason the crisis card was developed was for exactly this reason, and now what we're hearing, and that's the reason for these meetings, is that the crisis card itself is not enough. So we need the crisis card and a letter. So that's that.
Can I just say in relation to the card, I live in St. James's Catchment, is my hospital. Thank you. In relation to the card, I'm in St. James's catchment area, but I go to Vincent's for my net. And I had a situation where the ambulance was called and I showed them the card and said, I have to go to Vincent's. And they said, no, we will not take you to Vincent's. And they ignored the card.
So that is a national ambulance policy, and there is no card will affect where you get brought to you legally, and from an insurance point of view, have to be brought to the nearest acute facility when you're in an acute ambulance. And the only way to avoid that is to decide, well, okay, I'm well enough to get a lift or get a taxi to the hospital of my choice. But you can't really make that decision when you're acutely unwell and you phone an ambulance. But ambulance goes to nearest hospital. And that's one of the issues where, so I work in Loughlinstown, and 20 years ago we were doing all emergencies in Loughlinstown, and there was stuff pulling into Loughlinstown that we just weren't equipped to manage, but they had to stop there. So we had to close our emergency department to make sure people got to Vincent's, and we have a different type of setup in Loughlinstown now that sees less acutely unwell people. So that's national policy, and no card will fix it.
It's my wife's a patient here. She suffers from NETS cancer. She's on 28 injection every 28 days, but she's been diagnosed now with DIPNECH. Is the injection good enough treatment for that?
We don't have a strong evidence to support that, but we do that. It's more of a trial and error, and to see if giving the somatostatin analog, first of all, will affect mainly the symptoms of the patient, and second of all, we keep an eye on the scans as well. So although we don't have strong evidence for that, but it's one of the options.
Oh, just you want to say something?
No, I was just on that point. Sorry. We also have in Vincent's a rare lung clinic and under a respiratory consultant. So if your wife hasn't been referred there, that's a good idea with DIPNECH to go and see that consultant, and there's trials and research at the moment into this area. So you can let us know afterwards. Thanks.
And just because I have spent time practicing this, DIPNECH, which I was listening to it being discussed at MDTs, and I was too shy to ask, well, what does it actually stand for? It stands for diffuse intrapulmonary neuroendocrine cell hyperplasia. That almost deserves a round of applause. Thank you very much. And it's not a tumour. It is just the endocrine cells in the lungs just grow a little bit, and you can see them as little nodules. And some people with DIPNECH get cough and shorter breath. Most people with DIPNECH get nothing really, and we just keep an eye on it on the scans. And Cormac McCarthy is the respiratory guy who runs that rare lung clinic, and he wants to do a study using inhaled Everolimus, inhaled Affinitor, to see will that reverse the intrapulmonary cell hyperplasia.
Thank you all for a very interesting morning. My question is about PRRT therapy. I hear a lot about it today. Is that indicated solely for a narrow range of tumours and ET tumours, or is it possible over a more broad range? Medullary thyroid cancer is one. I believe it's a rare one, but it's just my own area of interest. Thank you.
Okay, so at the moment, it's licensed for a neuroendocrine tumor only, and only for patients with what we call gastroenteropancreatic neuroendocrine tumors. But for all others, like for example, even within the net, if you have your tumor in the lung, or as you heard in earlier talks, like if you have paraganglioma, etc. So although it's not licensed for these type of tumors, but we are offering this tumor as long as we can see your tumor showing some signs on the Gallium PET. So it is not licensed. We don't have good data outside the DIPNECH sites of primary, but we could consider it for other types if we see a good signal on the PET scan.
Hi, yeah. Hi, I'm just at the beginning of my NET journey, where I've been diagnosed with multiple neuroendocrine tumours in the stomach on a background of atrophic gastritis, and I've just two questions. I'm just wondering maybe what was the cause of either the atrophic gastritis or the NETs, and would PPIs have been a factor, because I was on long-term PPIs? And secondly then, because my treatment is just surveillance at the moment, is what lifestyle changes can I make? Is there anything that I can do to prevent it getting worse, like nutrition, coffee, anything like that? Thank you.
See if I can remember all the questions there. So most of the time, I think we don't really know what causes atrophic gastritis. It's relatively common. In some people, it's related to B12 deficiency. So, you know, what used to be called pernicious anemia. I don't think that it's caused by long-term PPI usage. To a certain extent, it produces the same effects, because in some people who have long-term PPI usage, you do see some growth of some of the glandular cells in the stomach, which can become close to looking like NETs. They're not quite. So there's a little bit of crossover, if you like. Most of the small type 1 gastric NETs, which is what you've got, behave in a very benign fashion. So it's enough to keep them under surveillance. It's a little bit over the top to go taking them out. And usually we use a size criterion, like we do with the pancreatic, the small pancreatic adenomas. They're very amenable to surveillance because they're visible on endoscopy. So you can reasonably reliably keep an eye on them. And I think it gives you the opportunity to identify a gastric net that's getting bigger to the sort of size where you want to get rid of it. And most commonly, if a type 1 gastric net gets to about 2 centimetres, it's advised that it's taken out. But a lot of the time that can be done as a minimal access, kind of laparoscopic or keyhole operation. So all the time trying to minimize the impact and function with these things.
It's Tommy Gorman here. Just to offer some additional information in relation to what Catherine from the HSE Treatment Abroad Scheme said. Catherine runs that unit that's based in Kilkenny for the HSE. And we're hearing lots of reference to PRRT treatment, lutetium treatment. That's what we have been availing of in Uppsala in Sweden. It's not yet available here in Ireland, will be available soon. Some of our Cork patients, a lot of our Cork patients are used to going for that treatment to Rotterdam, where there's an excellent centre and where there's a relationship between the Cork doctors and the experts in Rotterdam. One of the reasons why people from Cork are referred there is there's a direct flight from Cork to Amsterdam, so access is easy. Now, what happens when you go to Uppsala usually is for the first treatment, you might be there for 9 or 10 days. For the first few days, you have to be hospitalized because you're radioactive. For the rest of the period, it's possible for you to go to a hostel or to a hotel in the city. When you come back for your second, third, and sometimes fourth treatment, again, it's a short time in the hospital and then a few days in a hotel. Other thing that's covered is your flight cost, and if you have somebody accompanying you, which a lot of the time you will need just to have that support, that practical support, the gathering of information, that is covered too. So we're looking to try and replicate the Uppsala model for Rotterdam. In the meantime, if you're worried about it, if the cost is prohibitive and if you're from Cork, there is the option for you to ask your consultant, look, in the circumstances, can you send me to Uppsala while we try to improve it? Or you may wish to shoulder the cost while we're trying to improve it, but we're very conscious of attempting to improve it. The last point is in relation to the model that's going to apply in Dublin when we start PRRT treatment here. That's something we'll have more information about as the system is put in place. But what would be perverse as far as we're concerned would be that it would be more expensive for you to get on your pocket, for you to get the treatment in Ireland than if you were travelling to Uppsala or to Rotterdam. So we'll be very, very conscious of that. I hope that clarifies it. And from Catherine's perspective, and for the perspective of all the people sitting in the panel above, they're all on our side in this. And hopefully by the time we have our next meeting, we will have the Rotterdam situation ironed out to everybody's satisfaction. Thank you.
Sorry, the lady that asked 2 questions, she got the first one answered, not the second one, so she's repeating
John,
the
before
second
that,
question.
I just want to add a piece about what Tommy said about a companion going and that being covered by the treatment abroad scheme. It's only covered if the referring physician ticks the box that you need a companion with you. If that box is not ticked, then Catherine's department cannot cover that cost. So be aware of that and make your consultant aware of that.
Yeah, sorry, it was just, will I go ahead? Yeah, sorry, it was just the second part of that question with the gastric multiple neuroendocrine tumours. Just as I'm under surveillance, what lifestyle changes can I make to maybe prevent them getting worse? Like, does nutrition, coffee, tea, caffeine, anything like that? Just any little tips would be helpful. Thank you.
I don't think so. I mean, I think just get on with getting on,
I do think that the benefits of a healthy diet and physical activity are good for everything. So I think when you have any condition where you want your outcome to be the best possible outcome, then healthy nutrition, adequate hydration, and modest levels of physical activity. And by that, I'm not talking about going to the gym or running 10Ks. I'm talking about getting your walking in, your 10,000 steps in a day. I remember when I was about 42, I started to do my age +1 in press-ups every morning before I brush my teeth. And I am now doing a lot more press-ups. That's all. I haven't been in a gym in 100 years, and it's walking. So it's the small things that you do, nothing special, and that'll be good for every bit of your body. So it'll stop you getting other things as well.
Hello. I wonder if I could ask Professor Donald, please, to comment on the sandostatin injection, which is normally a 28-day intervals. When it's reduced to 21, what would be the 21-day intervals? What would be the thinking behind that change of regime, please?
Yeah, so when we sit at the MDT on the Friday mornings, we're looking for, as was said earlier, choosing the right treatment at the right time. And the sandostatin injections work very well at slowing the growth or stopping the growth of the tumours. If we look at a scan and we say, the radiologist goes, well, there's maybe 2 or 3 areas in the liver, and one of them looks like it's a little bit bigger, the others seem the same. I'm not sure if it's bigger, it's a very small change. Or, yeah, look, it's gone from 10 millimeters to 12 millimeters. We're not too excited about that in the context of a condition that's long trajectory, but we say, look, what we'll do is, rather than jump in with something like, say, Affinitor, or rather than say, would we consider TACE, we say, well, the first step is, let's give a little more of the sandostatin injection. So we'll reduce the frequency then to sometimes to every 21 days, sometimes to every 14 days. And that's the thinking behind that. It's where there's modest change, and we think we should make, if you like, a modest response to that change.
Could I just ask, following on from that, if you move to 21 days, would you probably stay at 21 days forever, or is it short-term 21 days?
Yeah, I should have kind of said that. It's usually what we'll do if we think we see something, and it's modest. We'll say, well, we'll make this change, and instead of re-imaging in 12 months, we'll re-image in 4 months or 6 months, and then make a decision. But often when people do move to that every 21 days, if at the next scan we see a little bit of further change, and we're saying we're going to add now a treatment, like, say, embolizing the liver, or, as has been mentioned, Affinitor, it will be in addition, and you will stay on the increased frequency injections.
Yeah. Sorry, just one quick question. It's in relation to the crisis card that we were talking about. I do think that would be where we heard reference there, where the ambulance people weren't aware of the crisis card and didn't really know what to do. And I think it would be very good idea that all of the ambulance services and that kind of areas would be actually made aware that such a thing is available and what needs to be done in that case. And I'm thinking of the cases where there's, say, a road accident or something like that, and somebody's being brought immediately into a surgical unit, and nobody's aware of the net being in the background, and it can cause then catastrophic results for that particular patient. So I do think it would be a very good idea if all people were made aware of the possibility of carcinoid crisis, and then in that way then I think we would avoid an awful lot of problems.
Sorry. Yeah, so so the card will be, sorry, the first alarm. So let's say you arrive in another hospital with a card. Obviously, there's no enough information on that, but it will be an alarm to the treating physician or the surgeon. And our experience with that, probably we could do more, we could do better, but our experience with that, when a patient arrived in another hospital and needed an advice for carcinoid crisis, they could immediately approach us. For example, there was one time a patient who's in the middle of a cardiac interventional procedure, and I got a call while the patient was in the procedure, and the cardiologist wanted to discuss the carcinoid crisis with the team in Vincent. So the card will be an alarm for the physician and the surgeon treating you in another hospital to contact the team for more information. And this probably is the safest way, because sometimes individualize the management of these, and is very good to be in direct contact with the team in Vincent. But probably we could do more with the information given and letters, as was suggested earlier, and through the website as well.
And for that road traffic accident scenario, the emergency services are incredibly well trained around airway breathing circulation. So when they attend an emergency scene, they look through wallets and bags for triggers like a carcinoid card, and their total focus is on the vital signs, the airway, the breathing, and the circulation. And they're the things that matter in a carcinoid crisis. So they will be at the scene managing those anyway, even if they don't find their crisis card. And then hopefully, and I think it's in the semi-elective scenarios that we need to make absolutely sure that there's a letter to back up the card, but you're not going to be at the scene of a crash pulling a letter out and saying, would you read this?
But I think as well, though, we need to make the emergency physicians know about this crisis card. So I think we need to promote it more within the medical community, that this exists, and can you be aware of it?
Totally agree, yeah. I mean, that's exactly, yeah, I totally agree.
On the broader spectrum, it looks like there's going to be people that's going to have a problem with a crisis, because surgeons, nobody knows it, and they may have this disease for some years, and they have an accident, they don't carry a card, never have carried a card, and they may fall into this crisis situation anyway. So you're not going to rectify this problem 100% no matter what you do.
But we should also make it clear that it's not for everybody who has NETs. It's only for those who can suffer carcinoid crisis, so those that have a carcinoid syndrome. So just make it clear, not everybody in this room needs to carry one of these cards with them. Like, I know I don't have functioning NET, I don't have those symptoms, so I'm not.
Just very quickly, that came up on the Facebook. No adrenal glands. I have one of these. No adrenals. Need cortisone. Contact. Medi-alert. You can have it on your wrist, or you can have it around your neck. The other suggestion was you get a tattoo on your chest saying it, because everybody opens your. Because with a contact number, and it's all it has to say is I risk of carcinoid, because you say, Donald, if you're in a road traffic accident, you may not be conscious. I have had episodes where I've been out of consciousness with adrenal crisis, and almost automatically I put. Yeah. So whoever's going to attend knows what's going on. So a Medi-alert, and it's internationally known, it has the snake, symbol, is maybe worth considering for patients. I was given this by Professor O'Higgins, or a model of it, after I had my adrenals taken out a long time ago.
Yeah, and the
32 years ago, actually.
You mentioned about the tattoos. That is becoming a trendy thing amongst our young type 1 diabetes population, to just have a little tattoo on their forearm or somewhere to say type 1 diabetes.
Get a QR code?
Oh, thank you.
I just have two questions for the panel, please. First one is, what's the difference between a PET scan in Cork and a gallium scan in Vincent's? That's the first question.
So they don't have gallium. So a PET scan, there's two types of PET scan, and I'm sure there's PET CT, which is a kind of a radio-labeled scan combined with a CT scan. And you heard about the different types of cancer earlier. The neuroendocrine, slowly turning over type of tumour. And that's what we do the gallium scan to detect neuroendocrine disease. The other kind of scan is an FDG PET, which is a glucose labeled onto the isotope, and that goes to, that doesn't show up in neuroendocrine disease, that shows up your more traditional cancers and tells you how quickly they're turning over. So the FDG PET is rarely helpful in a neuroendocrine tumor, and the gallium is the one that's the gold standard internationally, which is why, you know, we were sending people away for it a few years ago, and now we have it. Justin?
You're warm.
So good. It's a good start.
So it's the same machine. The radiology machine is the same machine. It's the isotope that's injected.
Okay.
So as Donald is saying, FDG goes where glucose goes. So when your cells are turning over quickly, if you've got a malignant tumor replicating itself at a high rate, that's chewing up glucose, so that'll light up on a PET scan. The isotope for a gallium PET latches onto the somatostatin receptor, the receptor on the outside of the cell that's looking for somatostatin. And the chemical that binds to that has got an isotope attached to it. And the problem is the chemical processing of that and the generating is a lot more complicated for the gallium PET. The actual chemistry of that, as opposed to the physics, is a little more complicated. So the half-life's a bit shorter. FDG is a little easier to generate. Okay. So it's kind of radio-pharmaceutical kind of problem.
All right, thank you.
That was quite good. That was quite good. And just you know, the field continues to evolve because in Germany they're now doing gallium MRIs and FDG MRIs, and obviously the big benefit of that is the radiation dose that you get from CT disappears. You'll still get the isotope dose of activity, but you know, the field continues to move on. So when I heard, oh well, in Germany they're using gallium MRI, I kind of went, oh God, you know, we've just got the gallium CT. We're very happy with it. And do we still have to think about yet again more stress on our radiology colleagues?
My second question to the panel is, when my neuroendocrine cancer was detected or diagnosed, I had very little symptoms, but it was very well established and extensive. And speaking to other people over the weekend, that's not uncommon, that people have been diagnosed, but the cancer is very well established, so it's been there a while. Is there any research or work, genetic-wise, into early detection of neuroendocrine, apart from the GP awareness program that Mark mentioned earlier? But is there any work being done on the early detection of neuroendocrine cancer?
Yeah, this is maybe, if you look at this from a different angle, maybe it's a good thing. It's not causing symptoms, because the reason a tumor can cause symptoms is if it's causing some pressure from mass itself, for example, causing blockage to the bowels, etc. And the other reason, if the tumor is active, and as Mark said, not all neuroendocrine tumors are active, not all of them are functional, not all of them cause carcinoid. So if you have the symptoms of the hormones, it would be maybe obvious, although most of the time it would be misdiagnosed as well as like irritable bowel, or if you have the mass effect. Otherwise, it is very, very difficult. I mean, we have markers, for example, chromogranin A as one of the patient ask, and others. But again, why the GP would check these if there is no symptoms? So you know, it's very difficult.
Can I say, I think really the only thing there is education of the clinicians. Like, I mentioned the GPs, but we also need to educate the endocrinologists and gastroenterologists, the ones that aren't involved in NETs, so that when they get a patient referred with gastric issues, you know, that maybe they know that there's a thing called neuroendocrine cancer, and they're suspicious of it. That's really the only way we can go, is education of these clinicians. Because we're rare, it's very hard to get their attention to actually look at this information.
I think one of the technologies that might make an impact in terms of screening is this idea of a sort of liquid biopsy. People talk about taking a blood test and looking for little strands of DNA floating around in the blood. That is a really hot topic at the moment. You know, the idea that you could take a blood test from somebody and screen for a whole range of possible cancers by picking up traces of DNA from the tumor that are actually have been detached from the tumor and are floating around in the blood. And I'm not aware that that's impacted on the net tumor types yet, but it seems very likely that would be one of the kinds of tumor you could screen for at some point. I mean, all the attention is focused on the common cancers, you know, colon, lung, breast, and so on, prostate. But I mean, the same logic would apply to screening for scraps of DNA coming from neuroendocrine tumors. You know, all tumors have gene mutations that occur that trigger the cancer. So it's likely most tumors will have scraps of these DNA floating around. So, you know, as it becomes, as the technology to process that stuff becomes quicker and more efficient, more and more tumors will come under the spotlight. I haven't read anything about that for NETs yet, but I'm sure, you know, within a relatively short period of time. That
There's
will come
the
out.
NET test. Have you heard of the NET test? No.
Not yet.
So no, well, there's a NET test, and it's undergoing. Hussein, you might have known about it.
Sorry, so the NET test, it's not available here yet. So it's again a couple of genetic markers you do with the bloods, and it's not only for diagnosis. It's, there are some studies about response to treatment, etc. So it's not in the clinic yet. It's not in the guidelines yet, but there is research in the area. But again, the question is about early diagnosis. I think this is your point from the question, and the question is, if you don't have symptoms, it's always very difficult to go for tests in the first place.
You have to have the suspicion of it. The
Yeah.
clinician has to have that suspicion.
In the case of my husband, the NETs was very, very established, and in blood tests in May, the blood tests were completely clear. The liver was completely clear, and yet in November was diagnosed with 16 mastitis in the liver. So you cannot rely on a general blood test, I would think. And I have another observation with regard to PRRT. It's a fantastic thing, but in some instances it doesn't work. I don't know if people are aware that in some cases, whether it's the severity of the tumors or what reason that's for, but in some cases it doesn't work. It actually doesn't work. And then I ask, is there side effects from the extremity of the radiation that person has to endure, and yet it hasn't worked, but does it affect other organs down the line?
Yeah, so PRRT, it's a very good treatment, but unfortunately it can't work for everyone. Perhaps looking at our data at least, it worked for 90% of patients. So there's still the 10% who are unlucky to have a beneficial effect from PRRT. With regard to the second part of your question, so PRRT, as we always do when we send a patient a new for PRRT, it comes with a side effect. It's like any other cancer treatment. So it's very rare to have side effects from it, maybe around 5% to the severe side effect, but it could affect the bone marrow, it could affect the liver, it could affect the kidneys, it could affect your blood count, etc. So there are side effects, and as you say, sometimes you go for PRRT, you can't get the benefit, but you are at risk of side effects. But in general, compared to other cancer treatment, the percentage of side effect is small, and overall around 90% will get benefit from that.
Can just say as well though, that not every patient is a candidate for PRRT. You have to have what's called a somatostatin receptor, So you know, not every patient will get it. And then you mentioned earlier that it's really only cleared for certain types of net, like GEP nets, even though you may try with other nets. But the toxicity, the patients do need to know about the toxicity and the potential for even leukemia that can happen from that. And I know you gave us some statistics last year virtually, Hussein, on what you observed in terms of toxicity.
So as you said, leukemias are prior side effects of PRRT, but if you look at all other cancer treatments, even any chemotherapy and etc., they all carries these risks if you read in the possible side effects. So they are rare, but they are possible.
I think we're reaching the end of the session. I hope most of the questions have been answered. I see a wave hand in that. Go on, one more.
Can you hear me? Yeah, there we are. This is an update to the Carcinoid Crisis question I asked earlier. From what Andrew just said, I'm ex-fire service as well, so paramedics and fire service always check wrist for bracelets, chest for a chain, for any medical alerts. If you can do what was just asked there and get the information together and get it so that it comes from St. Vincent, so we have that, I would say we could easily host that on a web page, and we could disperse then whatever the address is for that to patients, and they could carry the card then with medical alert across, which everyone knows, with the address. The paramedic arrives, sees it, gets his phone out, and he has all the information. And you know, it'll give the full information as to what he wants. So it'll be an addition to the information that would be on the crisis card as well. But on the side of the road, he can see exactly, just by reading a quick page, what the patient actually needs. Okay, thank you.
That sounds like a great idea.
Facebook page, the video on the Creon dosage from the net patient day that we had years ago. That's on our page, or the group, sorry. Okay, thank you.
I'm going to ask one final question, topical one. People who get COVID vaccine, there was a question sent in about side effects for net patients getting that vaccine, and they mentioned that this particular patient had a lasting reaction. Have you any comment really on that, on the vaccines?
So the COVID vaccine, everybody who comes into the emergency department will tell you when they had their most recent COVID vaccine, and for some it will be 3 days before their symptoms of whatever they're in with started, and for some it's 3 months, and almost all of them are wondering, could it have been the COVID vaccine? And after you have a vaccine, your system responds to that. So I think, was it on the Gallium PETs we see a little bit of, so on some of the PET scans recently, we've seen patients who've had a vaccine in the previous couple of weeks, and the lymph nodes under their arm are lighting up because their system is responding. So if your system responds, it could trigger a little more flushing in the few days after the vaccine, just like a viral illness could trigger. But in terms of lasting effects, we have very clear evidence that there are not significant lasting effects from the COVID vaccine for the vast 99.5, if not 99.95% of patients. So don't be hesitant when you get the opportunity for your next booster. Don't give it a second thought. Get the booster.
Okay, I think we're going to wrap it up now. Sorry if you had questions that didn't get asked, but the kitchen is under pressure to get us out and get food, lunch served. I want to thank our panel for a wonderful discussion. So Hussein, Justin, Catherine, Donal and Lisa, they gave their time to us for a long time today, and I really appreciate it. And to the speakers earlier, I think we had a great morning session, a lot of information. I hope you learned a lot. Thanks to you for coming along and for asking the questions, which made it a great Q&A session. I want to thank Paul, Michelle and Sean at the back for recording this. We will have it hopefully within a week or two available on our website to watch and watch back. We do have our previous sessions, like the last 10 years of these events are all recorded, well not all recorded, mostly recorded, and they're available on our website and the YouTube channel that you can watch. And we've actually taken out a lot of the questions like you had today are available to, like not your questions, some other questions been asked along the way are all available to watch and listen to the answers. Some of the stuff is excellent, and you may find it matches your condition and your question. But thank you so much to everyone. Yes, we really need new members on our committee. You don't have to be a patient, you know, a carer, family member, whatever. We want people who would like to participate, help us out. There's always a lot to be done. So please put your hand up, come and talk to me or one of the other committee members, and get involved. You know, it's very rewarding. And like today has been wonderful. I hope you've all enjoyed it. But to talk to patients along this journey with us is so helpful to us and rewarding. So with that, thank you very, very much. We're going to have lunch. It's going to be in the room here. I think we're probably needed either to stay here or to move outside. So move outside, I'm being told. So if we go outside and come back in about 20 minutes' time, we'll have lunch. Thank you.